Welcome to the Health Workforce Technical Assistance Center's webinar series. This presentation is entitled Using Medicaid Claims Data to Calculate Capacity for Federal Shortage Designations, Part 1, and it was presented by Eric Turer on May 24th, 2017. Hello, my name is David Armstrong, and I'm the Director of the Health Workforce Technical Assistance Center. And today's webinar focuses on using Medicaid claims data to calculate capacity for federal shortage designation. But before we get started, I'd like to introduce today's speaker. Today's presenter is Eric Turer, a Senior Health Services Consultant at John Snow, Inc. Welcome, Eric.
So this is a two-part discussion, the way we've laid it out. So today I'm kind of going to run through the process for using Medicaid claims data in the shortage designation process specifically, and if we have time at the end, maybe some other notes about how to use that data. Yeah, and the idea is that the second part would be somewhat more technically oriented. There's some parts in here that sort of are about data manipulation specifically. So today we're going to talk about the process. In the second part, we'll sort of use a dummy file that sort of mimics the data that we'd be looking at and show some of the techniques about how to make the connections, basically using an Access database, Microsoft Access database. So there are pieces of this where I'm and I'll mention where I'm sort of going to gloss over some of the underlying technical requirements for doing some of what we're talking about. Certainly, as I go along, if anything doesn't make sense, just use the hand raise button in the WebEx, and David will see that you're wanting to jump in if you're muted. And otherwise, I'll stop once I've sort of gone through the whole process, because there's a number of sort of sequential pieces that I'm going to be describing. So anyway, hopefully that is a good understanding of where we're starting from. So let me just sort of lay out for today. The idea is to consider the benefits and pitfalls of using Medicaid claims. And I will say, like everything, there are some benefits, there are some pitfalls. Overall, I am a big fan of the Medicaid claims process for a number of reasons that I'll get into later, as opposed to the old survey process of getting Medicaid data. We'll talk about how to obtain the Medicaid claims data, what you're actually going to be sort of trying to obtain and request from the Medicaid folks. And then once you've got it, what to do with that data, how we would process that data to get the information needed for capacity analysis related to HPSAs and MUAs, or I should say MUPs, since this is focused on Medicaid data. The other thing is, once you've got that part done, you then still have to connect the data back to the SDMS system, which also has some complexity to it that it's worth discussing. And again, at the end, if we have time after the questions, I'll run through a quick summary of some other things that I think are really great uses of this data, as long as you've gone to all the effort. So the general concept, claims-based capacity analysis, is very simple. At the top level, you're basically taking a visit count per year and equating that with what we used to count as an FTE using hours, so full-time equivalent. And so you're adding up claims across all the different providers that take Medicaid and deriving an FTE from the activity that you're seeing in that file. And as with the process overall, this is focused on physicians and dentist claims only, so physicians being medical and also mental health. It's not really a description of the non-medical or the non-physician part of mental health, and it certainly, as with the HPSA process, attempts to exclude the non-physician providers who are also going to be in those claim sets. The process, as far as I've ever heard, is only officially allowed for Medicaid data. The reason I mention that is that some states may have all payer claims data sets. I sometimes go into a little discussion of those. Sometimes the Medicaid data is in the all payer claims data set, and that's one way of accessing it. But today we'll talk about it as though we're getting it directly from Medicaid. But I will say the process would be similar to what we're talking about. If you have all payer claims data set, it gives you the ability to do similar things with private insurance and self-insured entities and things like that. The way that they equate claims to FTE is very simple. 5,000 claims for a physician equals an FTE. 4,000 claims per dentist or psychiatrist equals an FTE. So once you're done adding up the claims that you pull out of this file, you do simple, division, and you've got your FTE number. The next point I think is pretty important. The claims definition process, how to define the claims, to extract the claims, to analyze the claims, what we're talking about today, is not defined anywhere in regulation or policy. So the idea of using it is, but the process for it is not. And I've seen sort of wildly varying approaches to getting this information. So I guess this is my JSI disclaimer. This is our process for doing it. We've done it across multiple states, and we originally developed it working with HRSA when they were undergoing the notice of proposed rulemaking to change the HPSA process. So we were the technical analysts for that work and got some data directly from CMS to sort of test some of the ideas there. So this has sort of been tested and developed in a number of settings, but it doesn't mean there's nothing official about it. Not to say that I think there should be some clarity and some consistency across states, hopefully. And the last one, I will say, I know, having worked in multiple states, the process of getting the data and the contents of the Medicaid data vary greatly from state to state. What you can get access to, what the restrictions are on using that data, how you get that access and how they share the data with you, and the content of those data sets can all be somewhat different. So this is kind of a lowest common denominator general approach to looking at things. When we get to the end and questions answered, I'd love to hear people's thoughts and ideas on what might be different in their state and what they've experienced. So the overview of the process, and I'll talk about each of these as we go. The first piece is to define the data request and the content. The next piece, which I think some people don't do, I'm a strong advocate, connecting the claims to other data sets, particularly the full MPI record for the providers that you're finding in those claims, and I'll explain more why. And then if you have license data and things like that, if possible, because again, it will generally require some way to connect it back either by a license number and MPI to the claims. The claims generally have MPI data in them. They often will not have license data, so it might depend on how your license files set up. And then the next part after you've done that, you basically process this to classify the claims. The way we'll describe it, you're going to get way more content in terms of claims when in the first extract than you want to use as capacity. And the process will be segregating out the primary care claims versus the specialty visits. And I probably should also say, physicians versus non-physician visits would have been a good bullet to have in this section as well. The other thing you'll probably encounter is individual versus organizational billing. And I will talk a little bit more about that process as well, because it doesn't always come packaged the way that you'd hoped it would be, or the way that SDMS ultimately needs it to be. So then that leads to the last point about disconnecting to the SDMS records. And as it said on the bottom, when you have organizational claims, if there isn't an individual provider, there's a process that has to happen in order to basically account for all of the activity in the state. Okay, here's the advantages that I see of the claims-based capacity analysis. First, it's statewide, so it's not just a spot here or spot there where someone's requesting a designation at a given time. When you do this, you will get statewide capacity. You will be able to look at Medicaid access across the state. The other thing that's in your claims is any providers in neighboring states that accept your state's Medicaid. There is a complexity with SDMS that won't really let you put your Medicaid capacity in neighboring states separately, but in terms of nearest provider and things along those lines, sometimes that's very important. The second point I think a lot of people don't recognize as a value, and again, it's a value in terms of if your goal is to get a designation. The ratio at 5,000 to 1 that they defined is very high versus sort of what an average productivity would be. So for physicians, we generally say that the capacity, averages around, say, 3,500 for a primary care physician in terms of visits per year. They're defining it as 5,000. So that means those same hours, if you had counted 40 hours, you'd be counting 1 FTE. If in those 40 hours per week over a year they can see 3,500 claims, you're going to end up with basically of that same provider. So it gives you a more favorable overall FTE count. I'm not saying it's a more realistic or accurate one, it's just more favorable for designation. The next one, I put the quote easier the term easier in quotes. I think it's easier than doing the surveys and browbeating the providers to try and get them to answer the question about what portion is Medicaid, and but there's some upfront work that is what we're sort of talking about today. You can update it once you've got the system down and the Medicaid knows what they're supposed to do. You can generally go back and get that data pulled again for a new time frame and fairly quickly get it updated. And the other thing that's nice about claims in general is it takes into account all the other stuff that you sometimes have to worry about. So for dental, there's a ratio by age that you're supposed to apply because people get less dexterous, or that's the thinking behind it as they get older. That'll automatically be factored in. Older dentists will just produce less claims. If they go on vacation or they take medical leave or they take maternity leave, that's all factored in. So you're not trying to balance out all these different factors. And even the dental auxiliaries, and the same is true for physicians. How much back office support do you have? That will be adjusted automatically by your productivity in terms of claims. So that all sounds good. Then the downsides, and then really I frame them as caveats. They're not really downsides. I'll talk about in a minute, but it's always a retrospective analysis. You're always looking back at data that's at least a year and usually a year and some months old. So it's not the same as doing a survey today to find out what's going on today. You need to assure complete content. One of the places where we mostly see gaps sometimes is with managed care organizations, especially if they're paid on a capitation basis or a risk-sharing basis. There are things called encounter claims. They're supposed to submit them in most states, but because it's not how they're getting paid, you can imagine that might not always happen, or even the data that's in those claims might not be as complete as it's supposed to be. So that's one thing to look at early on in the process. And then I mentioned the sort of bugaboo of the whole process is organization-level billing. Some Medicaid requires both and I'll mention this later on, but the attending or rendering provider, so the actual provider that did the visit, a lot of states don't get that data. And so all you're left with is, this health center or this hospital outpatient facility billed this many visits. And there's all sorts of sub-levels underneath that. So obviously SDMS does not allow you to put in organizational level capacity. They want it sort of drilled down to the individual provider. For better or worse, that has to be done. Sufficient address service information differentiation in the MPI. Every organization is supposed to split their MPIs by site and also by service within that site if there's very distinct services. Most of them do that. Some of them don't. So sometimes we have one place where we found a level 1 trauma center, tertiary care hospital, and all of their outpatient departments all bundled under one MPI. And if that's the case, then you've got a bigger issue that you have to deal with. Inability to directly differentiate remove specialist non-physician claims, National Health Service Corps. So if all you're getting is a big number for an organization, you basically at the first pass can only count it or not count it. Sometimes it requires additional digging to get down to this level, and particularly in the areas you're trying to designate. And bundled claim codes, just in general, that's always a thing. You're never quite sure what's in there when there's a bundled claim. So anyway, without talking down too much, those are some things that you have to wrestle with. Okay, so getting the claims data. The first thing I think is what I see mostly is people say, well, I just called Medicaid and asked them for a count of the primary care claims and I got the numbers. And to me, that's almost impossible to get exactly what you really need doing that, because Medicaid doesn't see the world the same way we do. And they, particularly the people who administer the claims data, probably don't know or even have the ability to define things the way we want. So this is sort of advocating for a more proactively defined process on the part of the request. The first thing I think is really important to try and have the discussion with Medicaid. A lot of times they have a data dictionary. It can be a lot to look through, but what you're looking for is to see sort of how is the data organized, what things are in there. Do they know the specialty of the provider? Some Medicaid does, some Medicaid doesn't. is there a data vendor involved? Because it doesn't help to talk with all the folks at the Medicaid department if the person who actually has to do the work, is an outside vendor that's not going to be party to that. A lot of times they'll want a data use agreement. I know you all are within a Department of Health, so it seems like not, but and maybe for some very legitimate reasons, sometimes data use agreements need to be executed, and those are going to govern what content you're going to have available to you. Once you get sort of to that point, my other thought is a lot of people say, I want to tell you what provider types I want. I'm generally a fan of asking for the activity for outpatient visits overall, and I'll define what that is in a minute. And then separating out after the fact the types of providers that you got. Because again, they're never at the organizational level unless they have individual provider activity. They can't really do that on their own anyway, and then you just won't know. So I think it's better to ask for everything in terms of the activity and then separate out on your own what's primary care, what's not. There's different ways that you'll get access to the data. So here's 3 ways that I've found that you can get access depending on the Medicaid department. One is what I'll just call a record level transfer. Every claim is one record in a big data file. So it produces often a very large file, depending on your state and how many fields you're going to get along with that data. But then you've got all the data, so it gives you a lot of control. A second way, which I think is actually quite useful, is live query access, where they can essentially open up a window, a query window, where you get a login and you can only access the fields that they've allowed you to access, but you can do it in whatever way you want. So you can, go in and run your primary care claim separately. You can go in and run your Medicaid claim or your dental claim separately, and then you can potentially pull the data in other ways or make other parameters on it that allow you to sort of explore the data and look at things individually. So I think this is a very handy way. And the nice thing is you don't have a big file to manage. You don't have any confidentiality. It's a tracked system, so you're not responsible for holding, claim data that could be sensitive. And then the last one is a summarized data request. So this is sort of, I think a lot of people go to this, where basically you tell them what they want, and they're going to pre-aggregate the data for you. It's probably the simplest thing because you just get numbers out the far end. But again, it's risky in terms of you have to tell them, so going back up to what's primary care, they have to disentangle all that before you get the data. And you're never quite sure if there's an issue. It's a lot harder to tell what might have happened or whether it's right or wrong. And again, at the bottom here, no matter what you get, especially if it's summarized data, I think should always be at the MPI level and at the address level. And ideally, they'd have more than one address for providers that work in different places. That's sometimes also a problem. But the MPI is sometimes sensitive. Sometimes they do not want to give the data this way. But I encourage that they do, because that really gives you the ability to see really who it is that's billing, rather than just aggregating to an address where that address could be a medical office building, could have all sorts of different provider practices in it. Okay, so defining the claim extract. So this is defining what you want from Medicaid. It has to be a 12-month time frame. So the whole concept of 5,000 or 4,000 visits is based on an annual time frame. It doesn't have to be a calendar year. It can be any 12-month period that you want. Sometimes if things are due at a certain time of year, you can pull that data set for the prior, not exactly the prior 12 months, but for a 12-month period that you think is complete. And this bullet below here is really a key thing. It takes about several months, sometimes I'd say 4 months at the outside, 6 months if you really want to be complete, for everything to what they call settle. So all the bills that were submitted have been processed. They may have been rejected, then the provider may have provided additional information. So, you want to basically make sure at least the very largest portion of the claims are all settled out by the time you do this. And then you're not picking up things that are, claims for people who weren't enrolled, or claims that were rejected for one or more reasons, or things that just haven't been submitted because the organization's behind in their billing. And I'll talk about the CPT codes in a minute in terms of what those CPT codes are. So CPT is a procedure code. It's basically a procedure code that represents a visit, and I'll show you which ones we use. It's a code that should be billed once for each visit, and it should be billed every time a visit is made. And luckily, for the most part, the codes like that is the way they're set up. The outputs that are needed, and again, I already sort of said this, at minimum, you need the MPI number for the provider and the service delivery address. If you have those two things and nothing else, you can more or less segregate your claims out and count the claims you'll need. It's nice when you have some additional information. And again, if you're asking for an MPI number, make sure to have the discussion about attending or rendering provider versus billing provider. They'll always have the billing provider. They'll always probably first want to give you the billing provider because that's what's important to them. That's who they're going to send the check to. Whether they have the attending or rendering is not always clear. But those are often the individual providers that are behind the organization. And so if you can get that level, you will save yourself a huge amount of work and also get a better, more accurate result. But again, keep in mind, that's not always going to be available. Service delivery address. Some Medicaid systems have an address on file for a provider, and they don't go further in terms of actually capturing the service delivery address. That's always a shame, sort of, when that happens. A well-set-up system will have each provider potentially registered separately, even if they're all under the same MPI. They may have some local Medicaid enrollee numbers or something like that give you more control. So you're looking to, and make sure they know, you're looking to find out where was the care actually delivered. And that sort of ties back into SDMS, obviously, as well. You know, the provider and organizational name, you know, if you've got their MPI, you more or less already know who they are. So that's not the biggest deal, but it's good to have. And then this count of claims. If you've got a record level data set, you don't need a count. You're going to do the counting on your own. But if it's pre-aggregated in any way, you know, to an address or an MPI number or anything else, you'll need to have them provide that count. And then these last fields are what I call optional. And what I mean by that is you don't need these, and if you get them, you probably then have to collapse them back to sort of this level up above here before you're ready to get into SDMS. So let me start off with this one. So sometimes, again, they know things that if we ask them, they can tell us, like what they think the specialty is. Do they know the care setting? You know, was this an urgent care clinic versus a primary care office building versus, you know, a hospital? And, you know, do they have IDs and addresses below that MPI level? The next one, patient zip, is absolutely not required. It's more for this piece that I'm going to add at the end in terms of what else you might do with the data. But again, if you can get it, it opens up a new dimension in terms of the data. And then the CPT code that's billed, I would say, is not required. I mean, we're defining the CPT codes. They don't have to dump them out. But sometimes it's useful for, particularly, there's a code that relates to community health centers, and it makes it a lot easier to find the community health centers, and then you can make sure that you're capturing things like the sliding fee discount. Okay. So let's just look at the codes themselves, the specifications, and literally you can give this to, you know, the Medicaid department and say, these are the codes we're interested in. You know, so if it's a primary care extract that you're looking at, there's basically two types of primary care codes. There's E&M codes, evaluation and management codes, and they're split up between new and established patients, and these codes determine how long the visit was, but we don't differentiate there. And then there's preventive medicine codes, same thing, new and established. So these are like your well visits and checkups and such. This last one's important. Community health centers, because they get paid on a prospective basis, cost basis, however you want to describe it, often use this code T1015, which is a HCPC code, which just represents a visit. It's a sort of a bundled, you know, complete visit code. And if you don't include that, you're going to miss a lot of your capacity from your FQHCs. Looking at dental, there's CD, instead of CPT, there's CDT codes, but basically oral evaluation and prophylaxis cleaning would be the two things we're looking for. And psychiatry is a little more complicated, and now there's basically psychiatric specific codes, which is this range that I've listed here, psychotherapy, the medical E&M codes would also contain some psychiatric capacity. So you'd then be going to look and see, all right, was it an E&M code billed by a psychiatrist, whereas in the primary care we'd be filtering them out. So you actually end up having to sort of do psychiatry in a two-step process. Where it says now directly usable for capacity, for anyone who's done this for a while, it used to not be, there used to not be a factor to translate claims into FTE, and now there is at 4,000 to 1. So that's good in terms of being able to directly apply that data. All right, so overview of the analysis of the extracted claims. You need to be able to separate out the non-PC, non-physician, and organizational claims. This next piece, connect to the full MPI listing of providers. This is important because basically if you just try and connect to your SDMS download of your providers, you will get a lot of hits on those providers. But all the organizational claims, you won't have any additional data on. You won't know anything about those organizations, what they do, sort of how they describe themselves, taxonomy codes. A lot of the individual providers in your state that are billing Medicaid might not be in the SDMS download because that's part of this process is assigning that capacity to the providers in your state. You know, the MPI might have them in a totally different state. And so I think it's important to go back and get the full MPI. I'll talk a little bit about that in a second. The downside is, and I'll show you a link of where it's found. It's a very large file. It's a national file of every provider that bills basically Medicare nationally and then some. So it needs to be opened in something other than a spreadsheet, or even Access can't open it. It needs like SAS or SPSS. And basically my process is develop a list of all the MPI numbers that I found in that claims data for Medicaid, and then just match it in to the MPI data and dump out just the ones that already appear in my claims data. And then you've got a much smaller, more manageable file. And then I also find you need to reduce, there's like 50 other identifiers that are meaningless for the most part, maybe keep the first few, you know, because otherwise it's such a wide file, a lot of other tools like even Access can't open it. But once you've done it once, it's actually a pretty simple process to get that large file, pull out the MPI records for your state, and then basically use that to match up to the claims. And here's my classification scheme, and I'll talk about this. I end up with a listing of claims, and I've got them classified into PC only, individual. So that means it's an individual provider, and I don't see any evidence of specialty care involved with that provider. PC only org is the same thing. It's an organization where I only see primary care. I don't see any specialty care. Sometimes I get PC mixed organizations, and that can be anything from a multi-specialty practice all the way up to, like I said, this tertiary care center that, you know, happened to bundle everything together under one big MPI number. And then this last one I consider optional, mixed PC individual. If you see somebody and they say primary care, internal medicine and cardiology, you know, it's a question of whether or not to count that person as internal medicine, you know, or cardiology. Maybe they do both. Maybe they got internal medicine first and then went back and did their cardiology. You know, so they have both, but what they really do is cardiology. In my experience, these folks usually tend to shake out as specialists in the end. And it's a lot of work to sift through this level, but it's usually worth classifying them and then go and look through that file and see what's in there and maybe reclassify some. Hopefully that makes sense. I'll talk about how you do it. So the MPI, I'm not going to go through a big discussion of this. Here's the link. If you go to this link, this is where you can download the entire MPI file. There's no login or anything. It's just sitting there waiting to be downloaded. You know, it's about 4 gigs, so it's big. There's a weekly updates, what they call the Delta file at HRSA, which again is, I don't think you need to worry about. It's better to just get the whole file at one time. And then the provider lookup is another place where you can actually go and look up anyone's MPI number individually. So if you have questions about a given provider you're seeing, sometimes you can go here and see what that provider looks like without downloading the whole gigantic file. You know, for example, someone who's not in that file, you could go up and look and see what might be going on. MPI number, 10-digit number. And then there's what's called a type field. So type 1 is an individual provider. Type 2 is an organizational provider. So this is another thing that by connecting to the MPI data, you'll know which ones are the individuals, which ones are the organizations. The taxonomy codes are in SDMS, so if you have that record, you'll see similar data there. But there's a code, which is very cryptic. This is a link which a lot of people don't know exists, but where you can go and look up those codes. In the next part of this presentation, I'll supply a file that actually has a crosswalk table, and that gives you the name of what it's actually talking about, so you can see what those other specialties are. Taxonomies have associated license numbers and states. Both of those things are optional, so they may or may not actually have the license number in the state listed. And then there's what's called a primary flag of whether it's considered their primary taxonomy. Again, that's not well defined, and it's also optional, so some people don't choose to connect one. But when you look at the file, it'll make sense. So you'll see a provider, they might have a few taxonomies. Maybe they're listed in your state, maybe they're listed in other states, maybe they're listed in no state at all. And that'll factor into how you might use them. But generally, most folks only have 1, 2, maybe 3 providers. The organizations may go a little further out. So look at the file and see how far out does it go. Okay, so these are the classifications. I'm not going to read through them, but what you'll notice is for primary care, there's a whole bunch of categories for individual providers. There's also all these organizational categories. You know, and you'll see federally qualified health centers 1, rural health, which means a rural health clinic, you know, primary care as an organization. CMS doesn't enforce. If you're an individual, they don't make you choose individual taxonomies only. And so what you might find is someone who says internal medicine and federally qualified health center. So I tend to treat these all as one big group and analyze them together, not really caring which classification they're falling into. Because otherwise you can end up excluding someone if you say I only want internal medicine and they listed federally qualified health center, they might come out looking like they're some sort of mixed specialty. You know, again, just something CMS doesn't enforce. Here's the ones for dental, same approach. The org ones are slightly different because there's a dental clinic here. For psychiatry, there's even more options. You know, there's mental health centers, adult mental health, adolescent mental health, mental health, including a community health center. So again, and all you do is connect these lists, and again, the file that I'll provide later on will have these lists already built in. The student and organized healthcare, this one's complicated. I'm not going to talk a lot about it. Obviously, we're supposed to count residents. A medical student can actually get an MPI. Mostly they don't need it. It's mostly for residents and interns. The problem is it's just one code, and so they may or may not have other specialties assigned. And so if you include this code, you'll be including all students in residency programs, including ones that you might not want to count. So I'd say it's worth looking at this group, figuring out which ones are involved, and also be left over from when they were in training program and they just never went back and took it out. So the issues with that. But keep it in mind, I didn't include it in any of these other lists directly. So the analytic steps, select, and this is what I do. So again, this is our process of coming to that classification system. I try and create a file that says PC inclusive. So find any provider that has at least one of our primary care taxonomies. And I classify that by individual organization. Then I do a very similar query that looks for claims where they have at least one non-primary care taxonomy, regardless of whether they also have primary care. So I end up with 2 files that I call inclusive because they're including both things I'm looking for and then anyone else that might be mixed in nature. This note about, you know, sometimes with the non-PC ones, you may want to look for only ones that are definitively in your state or things like that. Again, it's worth looking at the file to see how that's going to shake out. Claims with both types, so if they end up in both the PC inclusive and the non-PC inclusive, it means that's a mixed provider. That's a provider that is listing both specialty and primary care taxonomies, and so that may require additional follow-up, particularly for the organizational level stuff. Don't try and look at this. It's really just a schematic of what I just talked about. So on the left side, defining PC, any inclusive, and so I've listed out all my taxonomies and see whether they fall into that primary care code listing that I mentioned. On the other side, I'm saying anyone where this lookup table of primary care taxonomies is null. So now I've got two files. I've separated my claims into the inclusive primary care and not, and then you just run those two files against each other. And so the ones that are in, so this is an example of the primary care one. This arrow means include everything on this primary care table, and only the matching ones if there's a non-PC record of that same provider, and I'm matching on the MPI. And again, I might match on MPI and address if I needed to. And in the end, I'm just looking for ones there where the right-hand table is null. So they exist in primary care. They don't exist in the non-primary care inclusive, so I know they're primary care only. Hopefully that made sense. And again, that's more what we'll cover in the future version with the more hands-on piece. Last bit on assigning claims, I want to make sure I leave some time for questions, so I'm going to stop before I go into this next section. But assigning claims to the SDMS records, just a few thoughts. It's a complicated process, that's all I'll say, more than you would think it would be. I basically feel like you have to match on the MPI and the service address. Again, the MPI, you might find that provider working at multiple places in your claims data. You want to make sure you're putting those claims where they were actually generated, not wherever SDMS has that provider. So that's an important and somewhat complex process. All organizational level primary care claims need to be assigned and allocated. So this is also important. Make sure you're not missing the organizational claims, but if you do find them, what we do is we assign them to individual providers that we can find located at that address. Hopefully, usually we find enough individual providers. If you have access to geocoding and GIS is very helpful here, because the addresses will be in all different forms. So if you just say the street matches the street, one main street and one main ST are not going to match. So the geocoding is nice. It standardizes your addresses. The other thing is if you can geocode your license data, sometimes they might not be generating any Medicaid claims at that location, but you can find them in the license. And we don't really worry about what provider actually gets the credit. It doesn't really matter in the grand scheme of things. So we just assign them to different providers, making sure that we end up with at least all the claims that we found at that location assigned. The next piece is make sure tour hours exist, because again, if you're getting your tour hours from a survey, that survey may or may not have identified capacity at that location, or the provider may have moved, because again, we're looking at data that's a year old. And again, some valid providers might not even have an active MPI, so they'll get rejected by the SDMS system and probably need to be given to somebody else because, again, that capacity would shift. Usually if that person leaves or retires, somebody else probably, at least to some degree, will take over. So just dropping them is not really an accurate reflection. And then last but not least, when you're all done with all this, you still need to get sliding fee. That's not in the claims data, so there's still some manual process. But again, by finding your FQHCs and your big Medicaid providers, it usually helps you figure out, well, where might you look for that capacity? And this is just an example. So here's all the providers geocoded into those categories that I mentioned. And if I click again, I'll just show you a zoom in on one of these. This is really, you define a service area, you just sort of pick up all your claims. If I zoom in, and this is hard to see, but up here in this area, this is an example. What I'm trying to show here is an organizational provider that's seeing, if you can see here, it says 2,044 claims, and then several individual providers at that same location that are billing independently or under their own MPI some of the claims. So now this is how I can start to put together this question about who's going to get the credit for those 2,044 claims. The one thing to be aware of is don't just give them their portion of the 2,044. They also need to get their individually billed claims, because that's still capacity at that location. And the last thing, and then I'll stop and we'll do some discussion, is integrity checks. I can't emphasize enough. It is like this picture up here. It's a black box. You don't know what's in that claims data. And so it's worth doing a bunch of integrity checks as much as you can figure out how to do. Here's some thoughts that I put together. Look at the total visits that you got for your state versus the Medicaid enrollees. Or if Medicaid can give it to you, I'd say member years. So that's enrolled member months divided by 12 gives you member years, because that really tells you how long everyone was connected to the Medicaid system, because there's a lot of people coming on and off. There should be something like somewhere between 2.5, 3.5, maybe a little more claims per person in that file. If there's one, or I had a state one time where there was less than one based on the number of enrollees, that has to be wrong. Or, again, it would be very unlikely for utilization to be so low that, that there's less than one visit per enrollee. So that's what you're looking for as a reasonableness check. And again, it might be an indication that, say, the managed care is all missing or something like that, which you might not know. Look at the locations with the highest counts. That's always important and enlightening, and also basically gives you some sense that they're not just listing a billing office. They're supposed to list the service address, but they don't always. And so if they're if all the hospital's outpatient activity is ending up in one billing office, and you've got 50,000 claims in an office park where nobody lives, that's important. And Google is a great way to sort of look at that. Don't use the health grades or those others. There's a million of those services will come up. What you're trying to find is someone actually listing a service address. Another thing that I think is a great check is look at some of the recent low-income HPSAs that you did by way of a survey, if you have such places. Don't expect the providers to match exactly or matter which provider got the credit, but look and make sure that you're seeing sort of that same type of activity, same general group of providers popping up. And if the providers, look to see if there's providers with multiple addresses in the Medicaid file. If there isn't, that's an indication that you're probably not seeing the second or third location where these providers might practice. There might not be anything you can easily do about that if the data's not capturing it, but at least you'll know, or you can go back and ask that question if that's the case. So that's kind of the soup to nuts in terms of how to run through the data. Again, the last piece that I want to cover today is not part of the designation process specifically, but you've gone to all the trouble of getting this data and crunching this data. And again, some of this data, some of this that I'm describing particularly involves getting an additional piece of information like the zip code of the enrolled person. A lot of times it's not that hard to get that additional information. That's not a highly sensitive thing, especially if there's no other data attached to it, and again, if you're using a data use agreement. So let me sort of talk about what other things claims data can do, because I'm sort of a fan of as that slide showed, recycling this data to tell you as much as it can tell you. And a lot of times we've used this directly in answering the designation process questions. So these are other things that are obviously challenges for designation or for primary care capacity and access analysis in general. So what's an objective service area? How strong is that service? There's no such thing. I used to have a slide that had a picture of a desert island with one palm tree. That might be a perfect service area. But otherwise, anytime you draw a box around a set of communities, that's not a perfect service area. Some people are coming into those communities. Some people are going out of those communities. Do you know whether or not that circle or polygon that you drew is representative of the way people are actually using care? Whether that's ideal or not ideal is a separate question. But, and to what degree is there flow in and out of those service areas? Are you generally seeing people coming from surrounding communities? Are you seeing people from that community going out to other areas to get their care? You can identify pockets of need within service areas. So if you do a county-level service area, that may be a whole bunch of different communities all being lumped together, and the pop-to-provider ratio assumes everyone in that county's got the same level of access to all the providers there. That's obviously not really true, and you can use this kind of analysis to identify those places. Sometimes the neediest areas end up getting pulled apart into multiple other service areas, and that's kind of the shame of sort of doing service areas sometimes the way they are. Compare access to care in different segments of the population. So if your Medicaid data, or maybe even all payer data, it allows you to stratify. You could look at children on Medicaid separately, then you can look at women of childbearing age, often really different care accessing patterns going on there. examine better metrics of need compared to population to provider ratio. This is a whole other discussion, which I can't really do today, but things like, visit ratios, you can sort of figure out the number of visits a population theoretically would need, and then look at how many they're actually getting, or the ratio, the visits per person. So evidence of need, this last bullet, if you see, and we've seen this in other areas, that the places where people go the furthest for care might also be the places where the lowest utilization is taking place. And you can use some tools in GIS, and this fairly simple table analysis, oops, I didn't mean to click that, sorry, fairly simple table analysis to get there. So again, if you ask for the 5-digit zip code of the patient, we call that an origin zip. Destination is where the provider was located when they got the care. If you use that combination, you get what's called an origin destination matrix, which shows you every combination where people came and went to. Now, you probably want to take off the ones in the 2-visit combinations, because those, you could have someone from California that was visiting New York at the day they got sick, and they'll show up. You don't want to try and represent that, because that one person's going to look like they went 3,000 miles for care. But if you get down to, usually if there's 10 or more visits, there's at least some pattern established there. And what you can do, and again, this is another presentation, so I'm not going to delve deeply into it. You can find out what the preferred destination is. I'll show a map that's based on that in a second. If you apply travel time, which again can be done really fairly easily in GIS, it can figure out generically what's the travel time between these 2 zip codes, and then multiply it by the number of claims that took that route. So you can find out the average travel time for a community. You can find out fractional visits that exceed a certain time, so what portion of the visits are greater than 30 minutes, for example, or greater than 20 miles or something like that. How many visits per patient, how many visits per underlying enrollee, because that'll take into account the non-utilizers. So that's a whole bunch of analysis that you can do. And the next map is just a set of maps, basically, that sort of show this. So here's New Hampshire, and this was an all-payer data set. So these are much cleaner areas. Sometimes with Medicaid, you end up with some very strange patterns depending on what portion of your providers actually accept Medicaid. But each of these arrows pointing in, and again, the red spots are zip codes where the majority of the care of the residents of that zip code was provided in their same zip code. So we didn't put those stars on the map. They put themselves on the map. And then the other ones are communities where the plurality of their care goes to another community. And you can see they mostly go to these what we call kernel zips, these starred areas. There are a few instances where they sort of just go from one community to the other, but not mostly. And so it's showing you where the care is. It's showing you where the natural community is. And then the darkness of that pattern underneath it shows you how strong that community's preference is to go to that place. So here in the center of the state, this is our state capital. You can see it serves a very wide area, and the preference gets much stronger as you get in close. If you get into communities like this, where you're sort of being torn apart into 5 or 6 different areas, you see a very low preference percent. You see a very ill-defined sort of pattern of where people in that community go. This is Dartmouth-Hitchcock, so they get the strongest preference in the area because it happens to be not just a tertiary care center, but it's in a very rural area. So it's a strange combination, and it leads to a lot of strong care-seeking patterns there. Whereas in the more urban areas, like this part of the state, you can see the patterns are more torn up because there's more providers, more places that people can go, but you still end up with a spot like that where you're still in a gap between a whole bunch of providers, and those communities are being torn into different directions. So again, real quick review of that. This is just a zoomed-in review of that. Of the Concord area that sort of shows you what's going on and makes it a little bit clearer. So you can see, like over here, here's an example. Oh no, they're actually, still going to a kernel zip. This is one where nobody else comes into this community, but their primary service is by providers that are located there. So you can get a lot right just out of that data. Last bit, differential access patterns. So other things you can do. If you have all payer, you can split it up by insurance and see whether the private's going similar way to the public. You can stratify by your age and other things, as I mentioned. Diagnosis claim markers. So, you know, where do the diabetics go? This is something we're doing for a project in the District of Columbia right now. You know, how does that care-seeking pattern change by if someone has a certain diagnosis? Again, you have to get that data on the claims in order to do that. Then there's other CPT codes, so there's codes for other services like, you know, mammography, you know, where do people go? And then by overlaying it with underlying population, you can start looking at questions like, you know, adequacy and you know, again, travel time, travel distance, like we mentioned. So that's you know, that's just basically further selling the concept of doing all this claims analysis, you know, beyond sort of just the HPSA, you know, easier way of getting HPSA data that I think that was main focus. So let me stop. I know we're pretty much out of time, but I'm happy to stay on for a bit and answer any questions, or if you send anything after the fact, I'll try and hit them by email.
Thank you, Eric. I found that very informative. I especially enjoyed your conversation around like organizational level versus individual level billing, practice location versus billing location. I thought that was very interesting. And once more, a reminder to the audience, part 2 of this webinar series, we'll make an official announcement here in a couple of weeks, but we are planning to have it right now on June 21st at 2 p.m. And with that said, one last call for questions. Well, I'm not seeing anything come in, Eric, so I guess we'll just go ahead and wrap up today's event. Oh, actually, we do have one question, just in time.
For that mapping analysis with distance generation, do you need to have a special version of the GIS software? So there's kind of two answers there. So there's your basic ArcGIS, and I won't get into it, but they're sort of changing their model of licensing now. So hopefully everything will become even more accessible. I believe to just do the basic maps that I was showing with the lines to the origins and destinations, you can just create a centroid for each zip code and just use that to connect the lines. And that will give you that map with the arrows and the darker colors underlaying it. Again, the output for that is really just, you know, origin, destination, number of claims, and then depending on how you sort and flag those combinations determines sort of the kernel zips versus the, you know, the travels to other communities. To get time or distance, well, depending on how you want to do it, if you really want to do travel time, you need what's called the network analyst extension, which actually follows roads and speed limits and things and figures out those distances. You know, whereas the straight line, I think it'll do automatically in the desktop version. So you can get most of the way there with just regular desktop GIS. And then second question was from, hey, Steve, good to hear from you. Took some time on doing in Colorado. A lot of potential to imply. Okay, yeah, no, that's great. You know, like I said, we've worked with more and more states. You know, there's always variation in terms of what's available, but the basic content of what I showed here, most any state should be able to provide the data. You know, as long as there's good willingness from the Medicaid department to engage. So sure.
One more question just came through. What is the thought process to allocate organizational claims to individual providers of that organization? Would you consider tour hours?
So what I tried to say during the presentation is the hard part is basically finding the providers that are located there. And that's not always that easy. Sometimes, you know, they're billing individually to Medicaid so you can find them, or sometimes you've got the license data, and so you can find them that way. Once we find them, we don't really worry too much about who gets the credit for what. So, you know, if we've got, say, 12,000 claims to be allocated and we can find, you know, 4 providers, we'll give the first 2 $5,000 each. We'll give the next one $2,000, and then the fourth one won't get anything. So, you know, again, in a way, I sort of wish the SDMS system did allow organization-level capacity to be recorded directly, because it would actually be, you know, probably more accurate, but it's just not the way it is right now. So it's mostly making sure that you're getting the data into the SDMS system so that the capacity is being reflected correctly. You know, it's not really meant to be a system that, you know, evaluates the productivity of a given provider. And again, if they've got 12,000 visits, you know, it may be, many more providers that are generating those, than the ones that are going to end up with the capacity. Or you can spread them evenly. It's just a little more work to then allocate, to each of those individual providers. But yeah, it's never really been totally clear why the focus on making sure that you're picking up the individual providers at that location when it's mostly about overall capacity.
Okay, Eric, a quick follow-up question, and then I believe we'll go ahead and wrap up the event since we're going over time.
Sure.
What if they are located in different HPSAs?
The they being the, could you clarify that?
This is a follow-up to the last question. I'm sorry, I interrupted your thought process there.
So again, it's all by location. So you could have one provider who actually provides care in multiple HPSAs, but what we do is we look at the capacity at a given point. So if that organization is showing, say those 12,000 claims at a particular point, then then we would basically give them the credit there at that one particular point, and that's going to fall in or not in any given HPSA. If that provider's in multiple locations, the SDMS system lets you add multiple locations for a provider. So that's how you'd handle that.
Okay, and here's one more. I know we said that would be the final question, but we got another good one in. And so let's just try to squeeze one more in, and then definitely I think we need to get out of here. But just a reminder for those in the audience, we are recording this event, and so you can check it out on our website here in a couple of weeks if you have to take off to a meeting or something. Here's your question, Eric. Have you looked into how the Medicaid data impacts the geographic HPSAs? For example, if you create address sites for each provider based on Medicaid claims in SDMS, that would create tour hours of 40 for each site address.
I'm not sure I quite followed that, but let me take a stab at it and then let me know if I got it right. The 40 that it defaults in is just a starting point for the tour hours. So when I say make sure there's tour hours there, if you put the Medicaid claims, it does require you to put a certain amount of tour hours associated. If you're not worried about the geographic capacity or you don't have a way of getting the actual tour hours, then that's a separate question. If you've got the tour hours, then you can put, however many hours they work there and then however many claims. And there's no integrity check built in to say, all right, is the number of claims reasonable other than for the number of hours there, other than that there have to be some hours. It won't accept just claims with no hours. So if you create multiple locations for a given provider, don't leave all of them at 40. If you have any ability not to do that, then certainly they should be adjusted. What I like to do after uploading into SDMS is re-download the entire state and then look for any provider that's got more than one FTE in terms of either claims or hours, just to make sure that nothing, because again, when you're doing that uploading, you've got multiple sites and you're trying to match sites to providers. The one thing I'll do is if I've got claims at a location that I'm pretty sure are right, but I can't validate the hours, at least in the first step, I'll assign at least enough hours there proportionally to make sure it covers the claims. And then if it's in an actual designation where it matters, then I have to do the follow-up work. Same's true with those organizational providers. If you get an organizational count, if it's in a designated area, you're probably going to have to call that provider and ask them more detailed questions so that you're getting rid of the non-physicians, you're getting rid of any specialists that might be there. You've got their sliding fee, things like that.
Okay, Eric, and once more, thank you for the very informative webinar. But at this time, we'll go ahead and end the event. And for those of you in the audience, I hope to see you again on June 21st for the second part of this series. And to everyone, have a good afternoon. And thank you out there for attending our webinar. Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.